It's going to be okay.
You'll be fine, inshallah.
In the UK, some 5 million major operations are carried out every year.
Nerves are kicking in now. Good luck, we've got it.
We'll keep you safe, okay?
But some patients' procedures are so complex, only the most skilled surgeons can perform them.
There's adrenaline,
Knife, please.
anxiety,
Lock on, please.
but as soon as you make the incision, everything goes.
Let's focus.
Serving Edinburgh and the surrounding area, NHS Lothian pioneers techniques to treat conditions that few others dare to take on.
You can consider it as a ticking time bomb.
But the cutting edge of modern medicine presents huge challenges.
Every time we operate, there is a risk that things can go wrong.
I'm in difficult territory.
Stop. Don't want to go any deeper than that. I think we'll damage her.
Anything less than perfection
We have a bit of a bleed.
can have grave consequences.
Tube clamp. Tube clamp.
The surgeons
Looks very abnormal, doesn't it?
bear the ultimate responsibility.
We can't offer 100% success in everything that we do.
Take that away from me. Give me this, thanks.
You wouldn't be human if you didn't feel the pressure.
You need to be very quick now. You okay?
This is what really happens behind the closed doors
That's a big chunk of the tumour.
of their operating theatres.
You've done something for this person that can prolong their life.
Beautiful. You can see the pulse.
You're waking up. Everything's gone really well.
It's one of the biggest privileges
I've got good news.
to help people the way we do.
The Royal Infirmary of Edinburgh provides some of the country's most specialised services. At the Department of Clinical Neurosciences, surgeons take on complex brain surgery, where millimetres can be the difference between success and failure. One of its specialist consultants is Imran Liakit.
I was interested in medicine from quite a young age. There's a little bit of an emotional connection because I had a sibling that had died of a head injury when she was very young. So I think having that scenario may have subconsciously triggered an interest in neurosurgery.
For his next operation, he's joined forces with fellow consultant Drahoslav Sokol.
I like Imran very much. We operate together, particularly in the cases that are quite complex.
It is important that when you're cooperating with a colleague that you have trust in each other and use each other's skill sets.
Their 25-year-old patient has a recurring tumour growing deep into her brain. If it isn't removed, it could prove fatal.
And she's got a diffuse astrocytoma. Over the last few years, there's been sustained but slow growth.
A decade ago, Drahoslav first removed the tumour, leaving a crater in the brain.
She was 14 when I did her first surgery. We removed that relatively smaller tumor at that time.
Following the previous surgery, the patient had a rare complication.
She suffered unusual retrograde amnesia, meaning she has not been able to recall events or persons or peoples from her past life.
I've never come across this sort of issue, which just shows you how unpredictable it can be sometimes. There is a high degree of anxiety that she may well develop memory loss after the surgery just because she had it before.
The tumour is spreading deeper into the brain and is on the verge of crossing into the left hemisphere.
If the tumour gets into those tracts and crosses to the left side, then we will probably miss the boat in trying to get complete resection of the tumour. And at that point, her overall survival will reduce.
Their patient, Veronica, lives with her fiancé Cameron in the East Lothian town of Prestonpans.
I had a really bad migraine about 2 months ago where I seen flashing lights, and that was the first time that I've ever had it. I definitely been kind of more distracted and My attention has not been that great and remembering things hasn't been that great, but I've also been going through quite a lot at work and we're planning the wedding for this year. So just put it all to stress.
Her slow-growing tumour has been monitored over the last 10 years. Recent scans confirmed it's now time to act.
They were kind of like, we think it's now time, especially if you're experiencing symptoms, to go for another surgery. There's just so many things that I want to do, and yeah, I think that's just kind of it. You know, no one should be in a position like me at 25, thinking that they might die.
It's not only the operation that's weighing heavily on Veronica, but also the fear she will suffer the same kind of total memory loss that she experienced after her last surgery.
I don't remember anything from sort of birth to the day that I woke up in hospital. I was in intensive care and I had what I was told was my mum and dad standing kind of in front of me, and I didn't know who they were. So just in case I lose my memory again, Cameron made me like a scrapbook of all our memories of how we met each other.
Ash means everything to me, absolutely everything. If she was to lose her memory, I'll just have to make her fall in love with me again, and we'll go from there.
Veronica's tumour is in the right frontal lobe of the brain, an area responsible for abstract thought, creativity, and concentration. Imran and Drahoslav must first identify what is tumour and what is normal brain tissue by probing each bump and indentation to feel a change in texture. Then they must carefully cut around the tumour without taking tissue that would cause a loss of brain function. But the tumour's tendrils are penetrating deep into the brain, and so, once the surface tumour has been removed, they will face the challenge of operating at a microscopic level, painstakingly removing it, millimetre by millimetre. If any tumour is left behind, it may quickly invade areas of the brain that the surgeons cannot reach. But if they disrupt healthy tissue, they could cause permanent brain damage.
The bit that's going to be challenging is the deeper bit.
Slow-growing tumours are often difficult to distinguish.
There is always a degree of uncertainty, whether it's tumour or normal brain.
The line they must tread between removing as much tumour as possible without damaging healthy brain tissue is a delicate one.
There is this eternal question of neurosurgeon, remove or not to remove. Now, would damage be really catastrophic or something that patient can live with?
My whole family are quite scared. They know that it's the best team. They don't have any doubts about the surgery itself. I think they're just more scared that if something was to go wrong.
Morning.
Morning. Veronica.
Can I take you to room 2?
Yeah, of course.
It's been 8 years since Drahoslav last saw Veronica and her mum.
Good morning. Remember me?
Yes.
So meeting again.
Yes.
Yeah.
So how do you feel?
Fine.
Good.
Excellent. It's not easy to think about doing another surgery, and particularly within a context of our previous complication. But we really need to remove the tumor to prevent further problems in the future.
It's 8:30 a.m. and across NHS Lothian, 55 operating theatres are being prepared for surgery, including Theatre 36 at the Department of Clinical Neurosciences. This morning, A team of 8 are preparing for Veronica's operation.
So we have a 25-year-old lady for a redo craniotomy for recurrent right frontal astrocytoma.
The more of this tumour we can take out, the better that it is for survival.
Can we send?
Yes,
Excellent.
absolutely.
Okay, good.
It doesn't feel real that I'm having the surgery.
I love the ones.
It just feels like I'm in somebody else's life right now.
Oh, sweetie, hang on, let me get you another tissue.
Sorry.
It's all right. You're doing really well. It's a big day, okay?
We'll keep you safe, take good care of you, okay?
Thank you.
So you split the hair and then we'll just do minimal shave.
Preserving cognitive function is very important. It's the essence of who we are as an individual, and that can be disrupted through actions that we as surgeons carry out. We do carry the complications. We've perhaps pushed the boundary of optimal resection, then that does weigh on you. Starting.
Imran makes a 20-centimetre incision from the top of Veronica's forehead to her right ear.
Yeah. Be really quick, please. In Veronica's case, we're planning on what we call a complete resection, so taking all of the tumour out. Detecting scissors, please. The evidence out there for tumours like Veronica's is that you need to try and remove at least 80–90% of the tumour to actually add survival advantage to the individual. All right, good.
Veronica's skull is now exposed at the same location as her previous surgery.
Perforator, please.
To access the brain, Imran drills a 2-centimetre deep hole through Veronica's skull. This enables a special jigsaw to cut out a 10-centimetre circle of skull, known as a bone flap.
That's all right, feed that.
Okay, so let's just loosen it up. Yeah, still stuck. There we go. Methadone swab, yeah.
The next stage is the delicate process of cutting through the dura,
That's in forceps and dissecting scissors.
the protective membrane that covers the brain.
The sutures are stuck. So in Veronica's case, because she's had previous surgery before, she will have scarring between the brain and the lining of the brain known as the dura. Yeah, it's too folded over. The brain is likely to be stuck to the undersurface of the dura, and there are blood vessels that sometimes can be stuck as well. And as you're opening the dura to gain exposure to the brain, you could damage these blood vessels. There's a wee vessel there, I think it's stuck. If I pull that vessel, if we inadvertently damage the blood vessel, it could result in a stroke, and that stroke could result in problems with speech or loss of power or sensation. Yeah, I don't want to tear it because it looks through the capsule, so it's just...
The brain is covered in a dense network of veins and arteries.
More vascular, I expected it to be. Okay, let's get the bleeding under control.
Besides complex neurosurgery, the Royal Infirmary of Edinburgh is also a centre of excellence for cardiac surgery. Heart and circulatory diseases are among Scotland's pressing health problems. 2,000 patients are treated at the cardiothoracic unit every year. Consultant surgeon Vipin Zamvar carries out some of the Royal's most complicated cardiothoracic procedures.
I always wanted to be a cardiac surgeon. I think the heart is the most important organ of the body. It's basically life.
He tackles over 200 operations every year and is known for pushing the boundaries of what's possible.
It is very important to push boundaries. I remember this quote, reach out and touch perfection in what you want to do most. What else are heavens for?
For his next case, he will be working with Registrar George Kamasidis. Their patient is a 71-year-old man who has severe coronary artery disease and will need open-heart surgery to save his life.
The disease is so extreme when the artery is almost blocked.
It looks very diffuse disease.
So the blockages are caused by hard plaques that form in the inside of the blood vessels. In this patient's case, 90% of the blood vessel is blocked.
Blocked arteries not only reduce blood flow to the heart muscle, they can also create blood clots.
The blood clots block off the artery, and in that particular case, the patient would have a heart attack, which in some cases can be fatal.
Retired auto electrician Sandy lives with his wife Shirley in Aberfoyle.
Gran took the children and Floppy to see an old castle. Well, that wouldn't happen. Would it?
They have 2 daughters and 5 grandsons.
Just about 6 months ago, pains in my chest. I was breathless. You know, it's quite obvious what it is. I will eventually have a heart attack. So here's hoping we'll get this sorted, and that's not going to happen.
Is that a different dog?
No, it's Floppy, isn't it?
I'd like to see my grandchildren grown up a bit and see what they become. I often think about that, you know, trying to imagine what they're going to be like.
Dad's a very active person. He loves to be outside. He's definitely living a smaller life than he was beforehand.
Here, Bella. Come on.
Get our breath just a wee bit, but hopefully in a couple of weeks that'll be fixed. Nerve-wracking a bit just thinking about it.
After you have the operation, when can you expect to be able to walk up the hill?
6 weeks or so probably, maybe more.
How are you going to manage with not being busy for 6 weeks?
Well, I'm sure your mother will have something for me to do.
You're supposed to rest for a while. Dad's kind of role in our family is the fixer of things, and I'm sure it probably is quite frustrating for him that he can't fix this himself.
He has quite severe disease in all the 3 arteries.
For an operation like Sandy's, most surgeons would first stop the patient's heart and put them on a heart and lung bypass machine.
If possible, I would like to do the operation using the off-pump technique.
But Vipin is one of a handful of surgeons who regularly operate off-pump, where the heart continues to beat and contract throughout the entire operation.
Even though it is technically more demanding, patients who have off-pump surgery, their recovery is quicker, better. They spend less days in hospital.
To access Sandy's heart, Vipin must divide the breastbone, a procedure known as a median stenotomy. Sandy's main coronary arteries are diseased and almost completely blocked, severely reducing the flow of oxygen-rich blood his heart needs to keep pumping. Vipin will detach the lower ends of the mammary arteries in the chest and divert them to 2 coronary arteries below the blockages. He'll also harvest the radial artery from Sandy's left arm and connect it from the aorta to a third coronary artery below its diseased section. But the arteries are just millimeters wide, and joining them together while the heart is beating is extremely challenging. Every stitch must be watertight to avoid a fatal bleed. Only when the bypasses are secured will a healthy blood flow be restored to Sandy's heart.
The best chance for a decent future is to have the operation. I would be living in fear, really, if you were just waiting a heart attack happening.
Okay. Okay, bye.
See you later. I'm a bit nervous, but it needs to be done. I do feel that I've got quite a bit of living to do yet.
In Theatre 4, a staff of 13, including consultant anaesthetist Julie Waters and surgical care practitioner Ewan Matheson, are preparing for Sandy's operation, which will be led by Vipin and assisted by George.
He's 71 years old. He has a long history of ischemic heart disease, and now he has diffuse disease. So we plan to do 3 grafts.
Just hope everything goes to plan. It all goes well, and there's not any problems.
Very nice to rest for me. Just relax, okay?
Before the operation, I play chess. Chess is about strategy, about thinking, about trying to outmaneuver somebody who's trying to outmaneuver you. Surgery is similar. You have a plan. At the same time, you think about everything else around you, what could go wrong, and make sure that you mitigate against that. Okay, starting, Julie.
Vipin makes a 15-centimetre cut in Sandy's chest.
Okay to saw?
Yes.
Good broad sternum. Even though I've done it thousands of times, it's an incredible privilege to see a beating heart, to be actually holding the beating heart in my hand. I'll never get used to it. It will never become routine for me. A small swab to me.
Now Vipin must decide if the operation can proceed off pump as planned.
That's the left anterior descending artery.
He manipulates the still beating organ to see how it responds when not in its natural position.
That's the obtuse marginal with the heart raised up. Some hearts are very big in size, they're covered in fat, and when you try to manipulate them, the blood pressure goes down and they're not stable. So in those cases, off-pump surgery would be difficult or may not be possible. Yeah. The pressures are quite okay. So we'll do him off-pump. Julie? Yeah. Left mammary, please.
Decision made. Vipin starts the process of harvesting the mammary artery on the left side of Sandy's chest.
Yeah, can we go flat, please? You and table moving? Yeah, okay.
While at the same time, surgical care practitioner Ewan begins to dissect the radial artery from Sandy's left arm.
Want it down a bit?
Just a touch. Otherwise, I'll be on my tiptoes for the morning.
That's the left mammary artery there.
Mammary arteries supply blood to the chest and are buried between the rib cage and the lungs. So Vipin frees it from the surrounding tissue using diathermy, a surgical cutting tool which uses a high-frequency electrical current to minimize blood loss.
How's the radial, yeah?
Yeah, it's excellent. Yeah, it's very good.
After 45 minutes of meticulous surgery, the first 2 arteries are harvested.
It's a good radial. We'll use the radial.
The left mammary will remain attached at the top, behind the collarbone. Vipin plans to join the other end to an artery which runs down the back of Sandy's heart, called the obtuse marginal.
The left mammary will reach the obtuse marginal very safely. I think God made the left internal mammary artery only so that cardiac surgeons could use it to bypass the artery at the front of the heart.
Vipin begins to harvest the final vessel, the right mammary artery.
So what do you think about the right mammary?
I think the right looks better than the left, actually. And this is the last one.
The arteries are all now harvested, but Vipin still has the most complex part of the operation ahead of him, attaching these tiny vessels to Sandy's beating heart, which will be constantly moving and pulsating throughout the entire operation.
Life is fragile. Things can go wrong very quickly, especially in cardiac surgery. You have to always be on your guard.
In operating theatre 36.
Right, okay.
That's okay.
Okay, can we get some wash, please?
Neurosurgeons Imran and Drahaslav have exposed Veronica's brain to start the process of removing her life-threatening tumour.
The brain still looks pretty normal. Low-grade gliomas often look like normal brain, and a lot of the identification is based on the feel of the tumour. It feels a bit more rubbery interior. Often low-grade tumours are a bit more rubbery than normal brain. Now the difficulty is that when you get towards the margins of the tumour, there isn't enough tumour cells to form that consistency that you had when you were in the middle of the tumour.
They employ a navigational device.
Can you get a pointer, please?
Allowing them to see where they are in relation to the map of the tumour taken from preoperative scans.
Brainland navigation is absolutely crucial. We need to go just deep enough to remove the tumor, but not to cause any damage to the important structures.
This gyrus here, I think there's tumour below it, right? If you take the gyrus down to here, that's where I think I want to go.
The tumour has spread into the bumps and indentations on the surface of the brain, known as gyri and sulci, in an area responsible for abstract thought, creativity, and concentration.
Leave this for now, and then we go into deeper into the
Do you want to take a bipolar and just buzz the margins on top?
Yeah, I think we do.
Yeah.
Imran maps out the perimeter using bipolar forceps that dissect tissue but minimize bleeding.
Yeah, that's quite extensive. Let me just see where we are.
It is more extensive than anything, yeah.
It always ends up being more extensive, I think.
Yeah. Initial resection, we are working within a margin of, let's say, up to 5 millimeters. The actual resection can be fairly straightforward and quick.
Ready to amputate it, yeah, from the bottom up. There we go. So that's a big chunk of the tumour. That specimen can go off to pathology. Can I just get the pointer, please? Thanks.
As we get deeper in the brain to areas that are more important or dangerous to get into, then we have to slow down.
After removing the bulk of the tumour, the surgeons use the navigational tool to assess the depth of what remains.
I think we've got a good margin. It's more figuring out the depths now.
The tumour is close to important structures, which, if invaded, could accelerate its spread.
The back end of the tumour, the bit that's beginning to extend towards the corpus callosum, and that's part of the brain that connects the right and the left hemisphere together. And damage to those deeper structures could be quite detrimental to Veronica.
Yeah, so we'll get a microscope in now, guys.
Now precision is key as the surgeons attempt to remove the final tendrils of tumour.
To achieve that precision can be very challenging.
That's the bit I want to go for, where the white matter is.
We are talking about a small layer of 1 or 2 millimeters thick, but it's important to remove for her future prognosis.
Can you get a Cusa pedal under my foot, please?
The Cusa is a suction device which fragments tissue using ultrasound.
I think you're reaching to the other gyrus.
Yeah?
Yeah.
Now we're going to be trying to remove the tumour that's in the white matter. White matter tracts are one of the most important parts of the brain. Some of the white matter tracts actually are what we call projection fibres. They're used in giving the signals for locomotion, if you like. And if you disrupt these cables too much, then you may lose function and not get it back. Now that white matter there you're seeing is probably
infiltrated tumour.
Could be infiltrating tumour, but it could also be...
We just don't know.
Okay, let's check.
It's already shifted the brain sac a bit, you know what I mean? So there's a few millimeter shift.
So let me go back in for that bit now.
The downside of brain lab navigation is that as the surgery continues, the brain itself tends to shift. Oh, but there is a shift, you see?
Yeah, but allowing for the shift.
Spinal fluid is released, which lets the brain to sag down a little, and also manipulating the tissues and removing the tissues changes position of the brain ever slightly. That makes navigation less precise as the surgery continues.
It's feeling like normal brain now, it's white matter.
Yeah, but I think it's going to be infiltrated.
It might still be.
There comes a point at surgery where we are not entirely sure if there is still any tumor left or if we need to go a bit deeper.
I think if we keep going ahead in the ventricle, it looks like we've got good resection. Don't want to disrupt too many white matter tracts.
Yeah, I wouldn't go deeper than that. Shall we stop here?
Let's see what the scan shows.
To find out if any tumour remains, Imran and Drahoslav need an up-to-date image of Veronica's brain. But the only way to do that is to stop the operation for an MRI scan.
So an intraoperative MRI is where a patient is taken into an MRI scanner whilst they're under anaesthetic in the middle of the operation to do a scan to see how much tumour has been removed or whether there are small remnants of tumour that have still been left behind.
A specialist radiology team, identified by their pink scrubs, now take over to perform the MRI.
Sarah, all surgical instruments accounted for?
Yes.
One last visual check on the patient just to see nothing hidden. Happy everything's away, Liz?
Yes.
Yep.
If the scan shows there's still tumour in Veronica's brain, Imran and Drahoslav will have to restart the operation.
If we leave any small remnant in these areas, it will very likely continue to grow. And if it grows further, it will likely grow to the parts we cannot remove. At which point, the survival is only a few years.
For patients like Veronica and the thousands who undergo MRI scans every year, the images produced are a crucial element of their clinical care. Maintenance of the Royal Infirmary's 6 scanners is the responsibility of the hospital's team of MRI physicists.
Medical physics is like the submarine of the hospital. Nobody knows that we're there or what we do, but we do play a really important role. We're backstage kind of staff.
Scanners exert a magnetic force 60,000 times stronger than the Earth's natural field.
MRI is one of the most immediately dangerous places to be in the hospital. You've got a very strong magnet that is able to pull magnetic material with great force towards the scanner.
The scanners are tested regularly to ensure they consistently produce high-resolution images without distortion.
We call this a phantom. So this is something which has been very precisely designed with a very specific set of features inside of it, which would correspond to very small features inside of a patient, a small lesion, say, or even a blood vessel. So if it does a good job of imaging this, then we can be confident that it will do a good job of imaging patients as well. This is the gold standard against which you're going to compare your scanner, basically.
MRIs work by harmlessly manipulating the protons within the millions of hydrogen atoms in the human body.
The protons in all our tissues are all randomly orientated, but when you put us into a scanner, then they all line up with the magnetic field of the scanner. And then the really clever bit is that then the scanner delivers a radio frequency that then knocks the proton out of alignment. And whilst it's doing that, it then emits another burst of radio frequency energy that the scanner can then detect.
By comparing the phantom scans to its known measurements, the physicists can analyze the images and decide if the MRI needs any recalibration.
That one is passing, so that's 1.1 millimetre. Struggling to see those ones though.
Yeah, I'd agree.
Yeah, so might need to up resolution on the scan. If I was having brain surgery and it was dependent on MR images, I would want to make sure that we have as high an accuracy as possible. We are providing that expertise, and I think that's the most valuable part of what we do.
In operating theatre 4, cardiothoracic surgeon Vipin is operating on Sandy's heart while it continues to beat.
Next, please.
He has finished harvesting the arteries needed to circumvent the blockages. Now he must safely mobilize the heart so that he can attach them.
The first thing I do is to put a stitch behind the heart. Stitch, please.
Using thick silk thread, he makes a stitch in the pericardium, the sac which surrounds the heart.
There's this fold of pericardium which runs across these two veins. The heart is kept here, and there's a sheet under the heart. So if you put a stitch behind the sheet and lift it up, the heart will automatically be lifted up. The benefit is that you can mobilize the heart in any direction you want, and you can access all the different parts of the heart.
This particular technique is a procedure Vipin pioneered.
That's the Zamvar pericardial stitch.
It's named after him and is used by many cardiac surgeons all over the world during off-pump surgery.
I think I was very lucky. There were many surgeons who must have noticed that fold. And I happened to describe it, and one of my colleagues suggested that it be called the Zamvar pericardial fold, and there it is. And then the Zamvar pericardial stitch as well. And that is so rewarding. And can I have a small swab?
Fewer than 20% of heart operations are carried out off-pump.
Okay, so we are all set now.
To give him room to operate, Vipin also creates space around the heart by removing redundant fat.
Do you play chess, George? Yes. Yeah, so like in chess, the person who has a space advantage has an advantage in the game. So when you're doing off-pump surgery, you need lots of space for the assistant as well as for the surgeon.
The heart can now be safely moved. Anaesthetist Julie Waters closely monitors Sandy's vitals while it's raised up.
I think we are pretty stable here.
Yeah, no problem.
Creating connections between arteries measuring just millimeters across requires skill, experience, and a steady surface.
Can I have the octopus, please?
So Vipin deploys a device to stabilize the areas he will be stitching.
There are vacuum pods here, so they stick to the heart like this.
As the arm is tightened, it steadies a small section of Sandy's heart.
15 blade, please.
Vipin plans to stitch the left mammary artery to the first diseased artery, the obtuse marginal. To do this, he must first create an opening below the blockage. But because Sandy's heart is still pumping blood, it will bleed profusely. So he must insert a hollow tube called a shunt to minimize blood loss while he stitches the bypass graft. The shunt remains in place until the last stitch is made. It's then removed and the stitches are quickly pulled together, allowing blood to bypass the blockage. Vipin will then repeat the process, known as anastomosis, for each blocked artery to ensure Sandy's heart has the oxygen-rich blood it needs to survive.
That's where we are going to do the anastomosis.
Vipin starts the first graft by making a small incision on an unblocked section of the obtuse marginal artery.
Okay, so we make a cut in the artery now. There is a risk that, especially while doing the anastomosis at the back of the heart, if the patient becomes unstable, you may have to crash onto bypass in the sense that the patient could have a cardiac arrest. There's a lot of blood gushing out. So it's in those 5 or 10 minutes, the patient will not have a circulation. Can I have a 1.5 shunt, please?
He must quickly insert the shunt to divert blood past the incision before he can start stitching.
The shunt is in now. We can take our own time to construct the anastomosis.
Painstakingly, using thread as thin as human hair, he makes a series of 14 intricate stitches to connect the left mammary artery.
Let's go down very slowly. Okay, so we've taken the shunt out and we will now tie the knot.
Which immediately creates a watertight seal.
Yeah, so that's blood flowing into the artery now.
And the first bypass graft is completed.
Okay, are you happy, George?
Yes.
Yeah, looks okay. So the OM is done, Julie. We'll do the radial next.
For the second graft, Vipin will use the radial artery taken from Sandy's left arm to bypass the blockage and create a new channel to the aorta at the top.
But I think it will reach.
Yeah, it will
reach. It's okay. It's enough. Okay. Can I have a size 1 shunt, please? I've opened the diagonal artery. It's a small artery. It measures about 1.25 or 1.5 millimeters in diameter. And I'm now trying to put a shunt in. Let me put it proximally first. Okay. The left. The problem is the shunt is a bit too long for the size of the cut that I have made in the artery.
Maneuvering the tiny hollow tube into such a tight and confined space is a complex procedure.
Can we have another size 1 shunt, please?
Can I get another size 1 shunt, please?
And throw that away, please.
With every second the shunt is not in place, Sandy is losing blood.
I'm worried a little bit that the shunt is not going in. Till the shunt goes in, there is a risk that you can have events and the patient can go downhill. If the shunt doesn't come out. Wait a minute. The new one, please.
In MRI 5, Veronica is undergoing a detailed scan in the middle of an operation to remove a life-threatening brain tumor. It's the only way surgeons Imran and Drahaslav will know if they have successfully removed all the tendrils of tumor deep within her brain.
That's what we're interested in, so where that crosshair is.
It's consultant radiologist Jerry Thompson's job to help interpret the scans.
This bright coloured bit here is the ventricle, and then this is the resection cavity here. There's some tumour between those two that's coming down towards the ventricle margin.
A tendril of tumour is extending towards the ventricle, a small chamber that produces fluid deep in Veronica's brain.
You want to avoid going into the ventricle because tumour cells can get into what we call the ventricular system, the system that's involved in the flow of fluid through your brain. And if that happened, you would be worried that the tumour could perhaps spread quite widely through the brain in the future. And there's a small, that bit there really.
So that's the triangle.
It's just this bit now that's heading towards the ventricle.
With a daunting task ahead, the surgeons quickly return to theatre and begin their attempt to remove the very last sections of tumour.
So you're right pointing at where we need to take it out.
That's where we are.
I think you need to go a few millimeters deeper in there.
And lower down as well. Okay. In Veronica's case, because she had, after the first surgery, some problems with her memory, we were wondering whether there's a degree of weakness in the brain. That feels a bit gritty. Because it's such an unusual complication, she may be more prone to these issues.
I would take that as well.
And damage to those deeper structures might result in a more severe deficit.
Keep going. I would take it deeper.
Yeah, okay.
Yeah.
We need to come superficial, not deep. Stop. Stop going any deeper.
There can be a time where one surgeon thinks, okay, we can still take another millimeter. Another one feels more apprehensive about this. Yeah, a bit more inferiorly. That's it. You just take that off. Yeah.
A little bit there. And then I don't want to go any deeper than that. I think we'll damage it.
No, it's okay.
Okay.
So you are right in it, so that's good. Like a triangle.
Tumor.
Those tumors, yeah. Firm. That looks very good.
Do you think you should go more?
No, it's good.
I mean, superficially, we can do a bit more.
And that's about it. You cannot really do more than that.
Okay. I agree. I think this is as much as we can do. Okay, that's the end of the resection.
They agree they have gone as far as they can.
It's paramount that a surgeon, particularly a reflective surgeon, knows and learns through experience when to stop operating, because perfection could be the enemy of good.
Even though they're confident they've removed all the tumour, the impact the surgery might have had on her memory is unknown.
I am very concerned that Veronica may wake up with a new cognitive deficit or may have similar problems that she had before. Until she's awake in recovery, answering my questions and demonstrating that her memory is normal, I would be highly anxious.
In Theatre 4, cardiothoracic surgeon Vipin is struggling to insert a shunt into a small incision on a diseased artery on Sandy's heart.
So whatever happens, the shunt will not come out that.
He needs the shunt in place to stop blood spurting out, but the cut can't be widened because if it's too long, he won't be able to securely graft the radial artery.
So it's so small, the shunt comes out easily.
There's no rule book about how to handle pressure.
Vipin has now tried to insert 3 shunts,
Can I have the size 1 shunt again, please?
but each has failed to locate and stay in position.
I think it is very important for the surgeon to be calm. Your team is there to help you. They'll do what you ask them to do. If you become nervous or you panic, then it shows and impacts on the entire team.
Very difficult.
The best thing is to bring the situation under control as quickly as possible. Once the shunt is in, there is a big sigh of relief. Now you know that things will not spiral out of control.
With the shunt finally in place, he can now firmly secure one end of the healthy radial artery to the second of Sandy's diseased arteries.
I was a bit worried earlier on, but I think we'll be okay here. The anastomosis is excellent, so that's good. I'm relaxed a bit now. Okay, good. We'll do the top end next, Rachel.
The other end of the radial must now be connected to the aorta, the largest artery in the human body.
This patient's aorta is very healthy.
5 litres of blood flow through it every minute.
Julie, clamping the aorta.
So Vipin must securely clamp a section of the sidewall to prevent bleeding as he makes a hole in it.
What punch are you using? is a size 4 punch. It's a nice 4 millimeter hole.
Having deliberately punctured the body's biggest blood vessel.
And we'll anastomose the radial artery to the aorta here.
Vipin must ensure the connection he creates fits perfectly.
And it's important to make sure there's no twist. It's very easy for conduits to get twisted.
Because this joint will be responsible for carrying a flow of high-pressure blood direct from the aorta to Sandy's heart.
Let's go down.
Complacency is the biggest enemy of any off-pump surgeon. No matter how experienced you are, if you become complacent, that's the first step on a very slippery slope.
Okay, anchor this, please.
With the radial artery from Sandy's arm now fully connected at both ends, Vipin moves on to the last graft.
What are you doing, Becca?
But anaesthetist Julie spots something.
Just the last one, the LED.
Right, doesn't like that much.
Sandy's blood pressure has dropped,
Pressure 66.
which indicates his heart, like any organ held out of its natural position for too long, is beginning to feel stressed.
I have pulled up the Zamvar pericardial stitch, and I've kept a swab between the heart and the stitch. And perhaps the heart is slightly more tilted than what it should be, and therefore the blood pressure has gone down slightly. So Julie just warned me that he doesn't like it.
Okay, okay. We'll just relax a little bit.
The third diseased artery is on the front of the heart and easy to access, so Vipin can relax the stitch, which has been holding Sandy's heart out of its natural position for over an hour.
So the heart is down now.
So it's very, very important, especially in off-pump surgery, that your eyes are on the ball all the time.
We'll let it recover.
That looks okay.
Sandy's vitals improve,
Okay, Becca. All right.
Okay. Yep. Okay.
giving Vipin the go-ahead to attach the right mammary artery, the final bypass graft of the operation.
1.5, please. Okay. Relax on your right hand.
This time the shunt slips in easily.
Okay, we are okay. Okay, let's go down.
The last graft is quickly attached.
Okay, bulb syringe, George. Cut this. The clip is off. The heart has got 3 new blood supplies now.
Even though the bypass arteries are attached, Vipin still needs to check they're all working and carrying sufficient blood,
Okay, good. Can we have the flow meter, please?
which he can do immediately because the Royal Infirmary of Edinburgh is one of only 5 hospitals in the UK with a high-frequency ultrasound imaging machine.
We're just going to make sure the flow in the 3 grafts is good so that we don't have to come back in the middle of the night.
Without this, any problems in Sandy's grafts would only become apparent after the operation, which could involve reopening his chest to carry out repairs.
Any PI less than 5 is fine, and the lower the PI, the better.
It provides an instant reading of how well blood is flowing in the new grafts.
So we have a PI of 1.4 here. That's excellent flow. Okay, so it looks good. What's the blood pressure? Blood pressure is good.
The 3 waveforms that we have seen, all 3 are just excellent. We do not have any problem at all with any of the anastomosis, which is very reassuring.
I was a bit worried about the diagonal, but it looks okay. So that's it, George. You happy?
Yes.
Leaving George and Ewan to close up.
Thank you. Yeah. Thank you, Richard. Thank you. Okay, thank you, Julie. I'll see you in a bit.
Vipin calls Sandy's family.
I'm just phoning to say everything has gone well with your dad's operation, and we did 3 grafts as planned. We didn't have any problems, and he's doing very well.
It's been 9 weeks since Veronica's operation to remove a brain tumour.
When she went into the operation, I was absolutely terrified. I was pretty convinced that she was probably going to die, or that she would lose her memory.
I think all of my family, and especially Cameron, felt a massive relief that this time around I didn't lose my memory. Hi, Measy. Hi, Measy Bugs.
When I saw her, I just burst into tears. I was so relieved that she was okay.
Hello. Hi.
Post-operative scans found no trace of the tumour.
They removed the entire brain tumour, so like they said 100% of it was removed. It's like a ton of weight's been lifted. I feel different this time. Like I feel like hopefully this is the kind of brain tumour saga being over and just planning for the future.
I'm so excited to see you in your wedding dress. I'm glad that you haven't shown me what it looks like.
Yeah.
See how beautiful you'll look.
Well, my hopes are that Veronica remains well and she has a happy marriage. And then I look forward to keeping her under surveillance. Hopefully just phoning her briefly to say that's your yearly scan and it doesn't show that there's any tumour that's come back. Hope you're well. A 10-minute phone call on a yearly basis, hopefully till I retire.
8 weeks since Sandy's triple bypass, and he's already back in the saddle.
I feel much better than I was before I had the operation. You know, I'm out cycling, going up hills, no pains, not out of breath. Feels really good.
He's no longer experiencing the symptoms which used to limit his life.
Dad's recovery's been incredible. He looks and feels great.
Now, that was quite a steep bit, and I got up it with ease. No even a deep breath.
I think actually we didn't realise maybe how unwell he'd felt before the operation, and maybe he didn't either.
Sandy is going to have a good quality of life. I hope that he'll be able to be a childminder for his grandchildren for a long, long time.
Right, boys, who wants a sandwich?
Oh, lovely. Cheese? Yeah, he likes cheese.
You get the Hoover out.
I know that we're all sort of really grateful to Mr. Danvar and all the staff that worked with Dad through the operation and through his recovery.
It makes me feel a good few years younger for a start. Right, who's beating who? There's a kind of roll-on effect for that everyone feels better, really.
It is always very rewarding to know that you've made a difference. Just last week, I got a letter from a patient who I had operated on 20 years ago, and he's just reminded me that he is doing so well. I think it is one of the joys of being a cardiac surgeon.
Next time, a painstaking search for multiple tumours.
This surgery might be very, very extensive.
And a battle to save a patient's eyesight.
The problem being that behind that is brain. The difference between success and failure can come down to millimetres.